I'm Carl Redding. I work at Mayo Clinic in Rochester, Minnesota. We'll be talking today about thyroid and parathyroid ultrasound. The superficial soft tissues of the neck can be seen with remarkable clarity using ultrasound. Today we'll focus on the thyroid and parathyroid, and specifically we'll look at nodular thyroid disease, which is the most commonly encountered pathologic process in this gland. We'll concentrate on a pattern-based approach, which is a practical method to distinguish those nodules that have a malignant appearance and require fine needle aspiration from those that have a benign appearance and do not require fine needle aspiration. We'll also see in parathyroid disease that parathyroid adenomas can be localized with a high degree of accuracy. And we'll begin with the thyroid gland. As we do, we need to obtain a perspective on nodular thyroid disease. And the first perspective is that thyroid nodules are very common. In fact, this has been called an epidemic by ultrasound by some. By palpation, these are present in 7% of the population. By imaging, by ultrasound, 40%. And at autopsy, 50% of individuals will have thyroid nodules. At the same time, clinically significant thyroid cancer is very rare. This is found at autopsy in 2% of the population, but it's only diagnosed clinically in 0.2% or 2 out of 1,000 individuals, and is the cause of death in only 0.005% or 5 out of 100,000. So just as there are very many benign nodules for the few malignant ones, there are many malignant nodules for the few clinically significant malignant ones. There's been some concern that there's an increasing incidence of thyroid cancer in the United States. This recent article in JAMA, it showed that in the last 20 years there's been over a twofold increase in thyroid malignancy. However, the conclusion was that this reflects an increased detection of subclinical disease and not a true increase in the occurrence of thyroid cancer. Also, at the same time that this incidence has been increasing, the mortality rate remains very low and has been stable throughout this time. And this is because most of these thyroid cancers detected in North America are a benign variety, well-differentiated papillary, or at least not an aggressive malignancy. That accounts for about 85%. A similar study in Korea showed that 95% of cancers were of the papillary type. And this is almost always an indolent and benign acting form of malignancy. It's not like most other cancers like colon or breast, where early detection is very important. Here the window of curability is much longer, and therefore that is why these are a benign acting form of malignancy. A third perspective is that the aggressive FNA management of nodules is quite costly. In our practice, a fine needle aspiration and the cytologic interpretation is $1,500. Also, 20% of these reports are going to be non-diagnostic. And there's variability in the cytologic report. It may say follicular cells present, cannot exclude follicular neoplasm. It's estimated that just the act of going and doing a fine needle aspiration on a thyroid nodule, that 10 to 20% of those individuals will then go on to have surgical removal at a cost of $20,000. And 60% of those nodules that are removed will end up being a benign nodule. Also, 5% of patients have some morbidity from the surgery, either nerve injury, chronic pain, hypoparathyroidism. So given that, our goals of thyroid nodule evaluation should be certainly to identify masses likely to be cancer, but for the majority of patients, reassure them that they don't have cancer and try to avoid an invasive and costly workup, including additional imaging fine needle aspiration and surgical excision when possible. So the options for thyroid nodule evaluation is that one can look at the size of the nodule or the appearance of the nodule or both. In our practice, we tend to concentrate primarily on the appearance of the nodule. We realize that if a nodule is malignant, there's a slightly worse survival with large nodules, but given that, we tend to concentrate primarily on that nodule appearance. Probably the best article recently on the various sonographic appearances of thyroid nodules was by Moon in Radiology last year. They looked at nearly 1,000 nodules in the Korean thyroid study group and very carefully looked at each specific feature of these benign and malignant nodules. In our practice, we tend to look at a constellation of features and put these together into specific types of patterns that suggest if a nodule is malignant or benign. Another way to think of this is that there are many thyroid nodules that we will all encounter in our practices. And what we're going to concentrate on today is the low-hanging fruit. These would be those that one would always or never do fine needle aspiration on. We realize there will be other nodules that wouldn't clearly fall into a specific pattern and might sometimes require FNA, but we'll concentrate today on the low-hanging fruit. So let's look at appearances that would either come to fine needle aspiration or not come to fine needle aspiration. And a typical appearance of a type of nodule that would come to aspiration would be this solid nodule in the isthmus of the thyroid. It causes some bulging of the capsule because of mass effect, and there are tiny punctate echogenic foci within it. And this is highly likely to be carcinoma. When one encounters a hypoechoic solid nodule with these fine calcifications, that is going to be papillary cancer with a high probability. Sometimes there won't be posterior acoustic shadowing unless the calcifications are clumped together. These tiny echogenic foci microscopically are believed to be, they're called somoma bodies. They're calcified laminated spherules that the pathologist can see. They're present in about 50% of papillary cancers. On real time, we can see that these have a punctate echogenic appearance within the thyroid nodule. Sometimes we'll see some faint shadowing if these are clumped together, but they're scattered throughout this large papillary cancer. Even when nodules are small, less than a centimeter, when they have microcalcifications, they have the typical appearance, these would usually require fine needle aspiration and generally would come to FNA in our practice. A second type of appearance that always comes to fine needle aspiration is the nodule that is solid and hypoechoic and has coarse or larger calcifications within it, and that's probable carcinoma. These coarse calcifications can be seen in papillary cancer. It's a dystrophic type of calcification, or medullary cancer. And that appearance indicates malignancy with a moderate probability. Our suggested dictation then, when we encounter a mass such as this, hypoechoic solid mass with either coarse or microcalcifications, we say that that appearance is suspicious for a malignant lesion such as papillary cancer, and FNA is recommended for further evaluation. A third type of appearance that comes to fine needle aspiration is the nodule that is solid in appearance, often more homogeneous, and surrounded by a thin peripheral halo. This is going to be follicular neoplasm with a high probability. Usually these are homogeneous and solid. Most of them are oval or round. They can have a thin peripheral hypoechoic capsule. We can perhaps see this best in real time where the homogeneous mass is surrounded by a thin capsule. Other times internally the mass is more heterogeneous, but still it has that often oval appearance and a thin capsule that surrounds the entire mass. If we see a mass such as this, then we would do fine needle aspiration. You can see the needle being inserted from the right-hand side of the screen, moved back and forth in a rapid fashion. It obtains small fragments of tissue, a material for cytologic analysis. This is then expelled onto a slide, and what the pathologist sees are many normal-appearing follicular cells, but they are more tightly clumped than one would see in just a benign type of aspirate. And the pathologist would then say that this is consistent with follicular neoplasm. They can't distinguish follicular adenoma from follicular carcinoma by the FNA alone, so surgical excision is generally recommended for further evaluation to exclude carcinoma. When the surgeon excises a nodule such as this, what the pathologist does is then finely sections this into thin sections and examines the capsule of the nodule. They look for evidence of capsular or vascular invasion, which would be a sign of malignancy. And statistically, more than 90% of these are going to be benign, but some will be malignant, usually a low-grade malignancy, when evidence of this capsular or vascular invasion is identified. So if the nodule looks like a follicular neoplasm, why do we even do the fine needle aspiration? It turns out that about 20% of the time the FNA will be read as negative and the workup then can stop. These are usually the macrofollicular follicular neoplasms, and they are benign acting, and the pathologist in looking at the slides will just say this looks like a negative aspirate. On the other hand, they may say this does look like follicular neoplasm. Can be a follicular variant of papillary cancer. It can have a very similar appearance or perhaps be non-diagnostic. In many cases, these will go on to surgical removal, but they may be observed or followed up clinically if you have a patient with multiple comorbidities. If the patient is elderly, it might make more sense to follow than to remove these for the low chance that they are malignant. And our suggested dictation when we see a mass such as this, a solid, moderate to large, homogeneous mass, we would say that the appearance is indeterminate. FNA could be done for further evaluation, knowing that many of these will be benign, but some could be malignant. So we've looked at several types of appearances that would suggest that a nodule is malignant, and they should go on to have fine needle aspiration. There are also appearances that suggest that the nodule is benign and that they don't need fine needle aspiration, such as this patient who has multiple small, predominantly cystic, non-palpable nodules in the thyroid. These indicate benign colloid nodules. They may be completely anechoic. They may contain internal debris. They may have small echogenic foci within them, and all of those appearances are very typical of these colloid nodules. In addition, we'll also see Comet-Tail artifacts behind these echogenic foci within the fluid within these nodules. It's probably some sort of crystalline material or other material giving this reverberation artifact, much like the cholesterol microcrystals that are seen in the gallbladder and give a similar type of Comet-Tail or reverberation artifact. One can perhaps best see this in real time, where we see the echogenic foci here within the fluid and posteriorly the reverberation artifact or Comet-Tail. Another type of nodule that doesn't come to fine needle aspiration is the nodule that's predominantly cystic but has multiple thin internal septations. It has the appearance much like a sponge with fluid-filled areas and then septations or solid material between the areas of fluid. And this indicates a benign non-neoplastic nodule in our experience, even when the septations are somewhat thicker, more heterogeneous, more prominent, and also even when the nodule contains these echogenic foci within the fluid-filled areas, as we mentioned previously. Sometimes there are so many septations that it almost looks like a solid mass with microcalcifications. But if one looks carefully, we can see that these echogenic foci lie posteriorly within these fluid-filled areas and giving the Comet-Tail artifacts. This is perhaps best seen on real-time images. This is a benign nodule on your left, a malignant nodule on the right. The benign nodule on the left, in real time, you can see the fluid, you can see the echogenic foci lying dependently in these fluid-filled areas and the comet tails behind them. Whereas the malignant papillary cancer on the right is completely solid. These echogenic foci are in the solid areas. There's some faint shadowing behind some of the areas. So what could look initially as similar types of nodules, if one looks more carefully, the nodule on the left has a benign appearance, nodule on the right, an appearance worrisome for malignancy. Our suggested sonographic or dictation when we encounter either a cyst or a sponge-like nodule is to say that this appearance is classic for a benign lesion such as a colloid or non-neoplastic nodule. And of course, FNA is not recommended. Another type of nodule that rarely comes to fine needle aspiration in our practice is the larger cystic nodule, even if it contains more prominent internal septations or debris within it. This is going to highly likely represent a benign non-neoplastic nodule, even if it contains large amounts of internal debris or thick internal septations. That is because these are not simple cysts. These tend to represent hyperplastic nodules, and these are the results of cycles of hyperplasia and involution of the thyroid parenchyma, which results in fluid-filled areas and some compressed solid material within the thyroid nodule. So a similar gross photo of a benign hyperplastic nodule in the thyroid, fluid-filled areas surrounding some compressed thyroid tissue. So the question would arise, could this represent a cystic malignancy? And the answer is it's possible, but it is unlikely. Papillary cancer can contain cystic components. It's uncommon when it does, and these are visible sonographically. They generally tend to be small components in the periphery of the lesion in this particular case. If that cystic area is larger, we can see the large amounts of fluid, and here there's a solid mass protruding into the central portion of the fluid, seen also on a similar gross specimen. And an additional finding, if we look closely, is there are also microcalcifications within this solid component. These are 4 additional predominantly cystic papillary cancers. We can see their large cystic components. If we look more carefully at the solid element, we also do see these microcalcifications located in each of these solid masses. That's not present in every case of cystic papillary cancer, but it may be present in many of the cases. Also, it looks like this is a common lesion. It's really not that common, but these are 4 examples of papillary cancers that are predominantly cystic. The way to approach this, though, is to say that as a practical perspective, the predominantly cystic nodule has an extremely high probability to be benign, because benign nodules are common, often have a large cystic component. Malignant nodules are rare and rarely undergo large cystic change. And even when they do have large areas of fluid, additional findings of malignancy, such as the microcalcifications, are often present. Our suggested dictation when we encounter a nodule that is predominantly cystic, such as this, is that we say the appearance is highly likely to be a benign lesion. One final appearance that does not come to fine needle aspiration in our practice is the thyroid that has multiple tiny hypoechoic nodules within it. And this almost certainly indicates Hashimoto's thyroiditis. One can have this predominantly micronodulation appearance of multiple hypoechoic areas within it, or larger hypoechoic regions separated by prominent septations. This is a very common disease. In fact, it's the most common cause of hypothyroidism in late stages of the disease. Usually occurs in women, has a prevalence of 4% of women. It's an autoimmune disease where antibodies develop to thyroglobulin. Grossly, the gland and microscopically will show these small lobules of lymphocytes separated by these fibrous areas, and that accounts for the appearance that we see sonographically. So here we have a gland with Hashimoto's on top, a normal thyroid gland below for comparison. You can see that with the Hashimoto's there's often diffuse enlargement of the thyroid, either multiple small hypoechoic nodules or these hypoechoic areas separated by the septations and bands. And we can perhaps more clearly see this on real time, where we can see these hyperechoic linear areas extending through this more hypoechoic regions of the thyroid. If one uses color or power Doppler, there's often increased flow within the gland, particularly in the acute phase or active phase of the disease, but that doesn't have to be present. There can be normal or even decreased flow in Hashimoto's. We also may see the predominantly micronodulation appearance on real time. You can see the multiple hypoechoic areas where these lymphocytes are present, giving the hypoechoic nodules. This is a very important pattern to recognize sonographically because it has a positive predictive value of 95% for Hashimoto's, and also in one study it was interesting that 3/4 of the patients had no known diagnosis of this before the ultrasound exam, so important to recognize this appearance. So when we encounter a gland with this appearance, we say there are multiple, or when there are multiple hypoechoic nodules in both lobes, we say that that appearance is typical of Hashimoto's thyroiditis. Well, let's now shift gears and move from the thyroid to another gland that is located immediately adjacent to the thyroid, and that's the parathyroid. We'll concentrate on patients with primary hyperparathyroidism. This has an incidence of 1 per 1,000 in the population, often in postmenopausal women, and 90% of the time caused by a single parathyroid adenoma. To localize these enlarged glands in patients with known primary hyperparathyroidism, we need to understand where the glands are located. In the typical individual, the superior gland, a patient will have 4 glands, 2 superior and 2 inferior. The superior glands are situated behind the mid portion of the thyroid or arrayed about this location. The inferior glands are situated at the caudal tip of the lower pole of the thyroid, arrayed about that location or trailing off into the soft tissues of the low neck. So behind the mid portion of the thyroid is where we look for the superior gland, adjacent to the caudal tip for the inferior gland. We don't see the normal glands in most individuals. We do see them when they're enlarged in patients with hyperparathyroidism. So the typical superior parathyroid adenoma on the longitudinal view is an oval, hypoechoic, bean-shaped mass situated behind the mid portion of the thyroid, and on the transverse view it's located between the common carotid artery and trachea in the triangle made by the trachea, thyroid, and common carotid artery. The typical inferior parathyroid gland on the longitudinal view is located just caudal to the thyroid itself, and on the transverse view, because we're caudal to the thyroid, it's located between the trachea and the common carotid artery. And it tends to be somewhat in a plane more anteriorly than the superior adenomas, which lie in a slightly more posterior plane. The typical adenomas are, as you've seen here, a bean-shaped hypoechoic mass, but there can also be a spectrum of appearances. They can be quite small, just a few hundred milligrams in size, to others that are very large, several grams in size. They're usually hypoechoic. Occasionally they can have large amounts of fat within them, the rare fatty lipoadenoma, or uncommonly they can have large cystic components. In all four of these cases, these patients were cured when these adenomas were removed, so there can be a spectrum of appearances, although these other appearances are less common. We can also use color or power Doppler imaging to evaluate these adenomas. We can see there's large amounts of flow. They generally tend to have a feeding artery at one pole of the adenoma, as we see here on the real-time clip. It enters through one end and then supplies the vascularity throughout the adenoma. Usually this is a branch of the inferior thyroid artery that supplies the parathyroid adenoma. It could be from the superior thyroid artery. It's helpful in terms of differentiating this from other types of similar masses. Thyroid nodules can be hypervascular, but they tend to have multiple vascular channels entering from multiple different locations. Lymph nodes have a single entering vessel, but it tends to be a low amount of flow and enters into the central portion of the lymph node and then branches in a regular pattern within a normal lymph node, as opposed to the parathyroid adenoma, where it enters through one of the poles. Multiple gland enlargement can occur as well in 5 to 10% of cases of primary hyperparathyroidism. This can be asymmetric enlargement of the glands. Here we see all 4 enlarged, but one may see 3 or 2 glands enlarged due to the asymmetry. It's just important to let the surgeon know that there may be more than one parathyroid gland enlarged so they can explore all of the potential locations for the parathyroid adenomas or parathyroid enlargement. Parathyroid cancer can also occur. This is quite uncommon. It accounts for only 1 in 200 cases that present of individuals with hyperparathyroidism. A clue is sometimes that the calcium and parathormone levels are markedly elevated, more than would be expected. But usually the diagnosis is made at the time of surgery when the surgeon encounters a mass which is firmly fixed to the surrounding tissues at operation. We can see that here with the lobulated contour of this mass extending and interdigitating into the tissues around it. So this was a parathyroid cancer, but most of the time the masses just appear as a large but otherwise normal appearing enlarged parathyroid gland, and the diagnosis is made at surgery. Most of the parathyroid adenomas are going to lie in typical locations, but about 2% can be frankly ectopic. And we'll look at the pattern that the surgeon employs to try to find these glands that may be mediastinal, retrotracheal, intrathyroid, or laterally in the carotid sheath or undescended location. When an inferior gland is ectopic, it has generally continued its embryologic descent along with the thymus into the anterior superior mediastinum. The surgeon, if they don't find the gland in the normal location, will then start to tease up the fatty tissue behind the sternum to look for these adenomas. We can do the same by angling behind the sternum, and we may see a bean-shaped mass within the more hyperechoic tissues in the anterior mediastinum. The same adenoma, even though it's located directly behind the bone, by angling caudally, we can often see these sonographically. The superior glands, when they are ectopic, tend to continue their embryologic travels into the posterior aspect of the neck or posterior superior mediastinum. If the surgeon doesn't find it more anteriorly, they tend to run their finger behind the trachea and probing more deeply into the low neck in an attempt to find these glands. Here we can see the same adenoma on ultrasound and CT. If we angle through the thyroid gland, we can often see these large masses here, this one located adjacent to the cervical spine. And they tend to be missed sometimes at initial operation because the surgeon may be reluctant to explore deeply in the neck because of nerves and other important structures, and these may be present when we look at these patients for reoperation for persistent hyperparathyroidism. Another place that the adenoma may lie is in a completely intrathyroid location here on the transverse and longitudinal view, completely surrounded by thyroid tissue. They are very homogeneous and hypoechoic, have the same type of appearance of a parathyroid adenoma that one would see elsewhere in the neck, but this tends to be completely surrounded by thyroid tissue. If we look with color Doppler imaging, they are quite vascular, as we see here, and if we're fortunate, we may see the feeding artery where that has been pulled into the thyroid parenchyma along with the parathyroid adenoma. The surgeons look for these. They tend to be quite soft, though. They're difficult for the surgeon to palpate. Fortunately, they show quite nicely sonographically from the remainder of the thyroid parenchyma. Finally, these parathyroid adenomas may lie laterally in the neck. It's unclear how they become in this location embryologically, but they can be within a sheath of tissue that surrounds the common carotid artery, internal jugular vein, and vagus nerve, the carotid sheath. And the surgeon needs to open this sheath and then look inside to see if they can see a mass such as this situated between the jugular vein and carotid artery. This patient also had a nuclear medicine scan that showed this activity in this place laterally in the neck, and the patient had had previous operations in an attempt to identify this, so certainly wanted even more information before having an additional operation. So with confirmation, fine needle aspiration was performed where a needle was inserted into the nodule, avoiding the vessels and obtaining material. On these aspiration biopsies of suspected parathyroids, they can be analyzed in three ways. One, the material can be sent for cytologic analysis with a small caliber needle. If the nodule in question is adjacent to the thyroid, some have used cutting needles because the pathologists prefer a larger sample to distinguish the parenchymal parathyroid cells from the parenchymal thyroid cells, and they have difficulty on cytology alone. But perhaps the best method, and the one that is in most wide use now, is to send the material for parathyroid hormone analysis. This is called a washout technique, where after the small caliber needle, such as the 25 gauge needle, has been inserted into the mass, it's washed with saline that's repeated several times. So at the end of this procedure, you have about a half cc of blood-tinged fluid within a standard test tube, and that material is sent to the lab. If the parathyroid hormone levels are markedly elevated, then that should represent parathyroid tissue. If they're at baseline with the blood or very low, then it should not represent parathyroid. And this is proved to be more sensitive and more specific than the cytology or histology. And if one uses these techniques we've talked about, a knowledge of the typical adenoma locations, a systematic scanning approach of the normal and the ectopic locations, and also using color Doppler and even fine needle aspiration as needed, then adenoma detection can be quite high using ultrasound. There are certainly other methods of parathyroid adenoma localization. Sestamibi scanning, particularly using I-123 or SPECT imaging, is very accurate and has supplanted ultrasound in some practices. Also CT using a triphasic technique with a rapid bolus of contrast. Here we can see an enhancing adenoma deeply in the neck adjacent to the esophagus. And we tend to use these techniques as well, but we often start in our practice with sonography, and if that's inconclusive, use these other techniques as well, particularly sestamibi scanning. One change in the treatment of patients with parathyroid adenoma that has occurred in the recently is the transition from the traditional type of operation to the minimally invasive type of operation to remove these parathyroid adenomas. There are certainly advantages to this. The traditional operation has a larger scar. With the minimally invasive operation, it's a smaller scar, less pain, and the patient spends less time in the hospital. So there are certainly many reasons to prefer this if it's possible to perform the minimally invasive operation. It does require excellent preoperative localization. Here on both ultrasound and scintigraphy, we've confirmed there is a hyperfunctioning nodule consistent with a parathyroid adenoma in this location in the neck, so the patient or the surgeon knows where to make the incision, the small incision, to remove this adenoma. So the precise localization is needed. One also needs intraoperative parathyroid hormone monitoring. As soon as this is removed at operation, the parathormone levels are measured. If they've dropped rapidly and significantly, then the surgeon assumes that that is all of the tissue that is present and closes. If the parathormone remains elevated, then they can convert to a traditional operation, explore other regions in the neck, and make sure there's not other hyperfunctioning parathyroid tissue in the neck. So in conclusion, we've looked at both thyroid and parathyroid imaging. We've seen that ultrasound is a powerful tool for evaluation of these types of masses, and I hope that this will be useful in your practice. Thank you very much.